Welcome, curious minds, to the deep dive. Today, we're plunging into a battle that's been waged for decades, impacting millions. It often goes unnoticed, though. We're talking about the global fight against malaria.
Hmm.
Despite all our science, all the efforts, malaria is still just an incredibly tenacious adversary.
It really is. A challenge of immense scale, certainly. But what's truly remarkable is the strategic approach, almost like detective work that the
Yeah.
global health community takes. Organizations like PAH and WHO.
Exactly. And our mission here in this deep dive is to kind of cut through the complexity of their strategies. We're looking specifically at malaria surveillance, monitoring, and evaluation.
Right.
We're drawing on this comprehensive manual from TAHO and WHO, trying to pull out the vital insights, maybe some surprising facts, and those crucial nuances that define how we fight malaria today.
And you're going to discover how data, everything from individual cases right down to mosquito behavior, it really forms the absolute backbone of this whole intricate battle.
Yeah, you'll see how countries have moved beyond just, treating malaria. They track it, they respond, and the aim is elimination, nothing less. And it's all driven by these really sophisticated, data-driven approaches. It goes way beyond just the doctor's clinic.
It really does.
So if we really want to get this fight, we have to start with a concept that fundamentally shifts the perspective: malaria surveillance. It's not just collecting data. The manual argues it's a fundamental intervention.
Mm-hmm. An intervention in itself.
Right, central to all operational activities. Think about that. Just gathering information is seen as crucial as, say, giving medicine or spraying insecticide. What does that paradigm shift really mean for how we fight this disease?
Well, it's profound, really. It means surveillance isn't passive. It's an active weapon. And what's fascinating is how this weapon adapts.
Adapts how?
So in areas with really high transmission, the focus is more on broad trends. You use the data to allocate resources, within the bigger health systems. But as a country gets closer to elimination, the surveillance becomes incredibly granular, super detailed.
Ah, okay.
It shifts to detecting, investigating, and then swiftly eliminating individual foci, those specific transmission hotspots. You have to stamp them out to stop the disease reestablishing itself.
That makes sense. Shifting from a broad brush to like a fine-toothed comb as you get closer to the goal. But what I find really striking is this principle that every single piece of surveillance data has to link to a decision.
Yeah,
It's not just collecting data for the sake of it. Does that put immense pressure on the frontline people to be analysts, not just data gatherers?
absolutely. It's a huge shift in mindset and capability, and it highlights something critical looking ahead. Countries need to invest in these robust surveillance systems, including the people, the human resources, before they even start trying for elimination.
Right, you need the tools ready before the mission starts.
Exactly. It's like building the sophisticated radar system first.
Yeah.
You need systems for immediate case reporting, for investigation, for response. They have to be fully operational from day one.
Okay, let's dive into the real core of this detective work. Defining and finding malaria cases. Sounds simple, maybe, but it's actually incredibly nuanced. There are precise classifications. We start with a suspected malaria case, that someone with a fever, maybe other symptoms, makes a health professional think malaria, but it needs that lab confirmation.
Right, the parasitological confirmation.
Then a confirmed malaria case means, yes, the parasite's presence is verified, usually microscopy or a rapid diagnostic test, an RDT.
And sometimes, when a definite diagnosis isn't immediately possible, you get presumptive cases. These people get treatment based just on suspicion to make sure they get care quickly.
But how do you even find these cases to begin with? There are two main ways, right? Passive and active.
That's it, passive and active.
Passive case detection is what we're probably most familiar with. Someone feels sick, they go to a clinic or hospital seeking care. Simple enough.
Yep.
But active case detection, ACD, that's where the real proactive hunt begins. And there are two types here.
Two types, yeah. First, there's proactive ACD. This isn't triggered by a known case. It's done regularly in high-risk groups or maybe remote populations. Think migrants, refugees, people working deep in forests, even long-distance drivers sometimes.
Why them specifically?
To confirm if there's local transmission happening under the radar, or maybe detect cases really early before they spread.
Gotcha. And the second type?
That's reactive ACD. And it's exactly what it sounds like. It is triggered by an index case or maybe a cluster of cases.
So someone tests positive, and then...
And then the health teams go out. They test household members, maybe other people linked to that first case, to quickly find and treat anyone else who might have been infected. It's about stopping further spread right in its tracks.
Okay, this classification of cases, This is where the detective work gets really granular, and it's, wow, surprisingly complex.
Mm.
For locally acquired cases, infections that happen right there are several types.
Mm-hmm.
First, autochthonous. That means contracted locally, no evidence it was imported or linked to an import, just local transmission.
Purely local, self-sustaining.
Then there's introduced. This one is strongly linked epidemiologically to a known imported case. So it's like the first ripple, the first generation of local spread from someone who brought it in.
Exactly, the immediate ripple effect.
And for certain types like PV-vax or POVAL, you get relapse. This is wild. The parasites reappear because of dormant stages in the liver, hypnozoites that can wake up months, even years later.
Like a sleeping time bomb, yeah. It's not a new infection.
And then recrudescence. That's also a reappearance, but it's because the initial treatment didn't fully eliminate the parasites. Same bugs, just reemerging.
Same genotype, yeah. The treatment wasn't completely successful.
Okay, so those are all considered locally acquired in some way. Then you have imported cases. Infection acquired outside the diagnosis area, right? From a known transmission zone or somewhere the person traveled.
Correct. And for global reporting, imported strictly means acquired in another country.
And finally, induced cases.
Okay.
These aren't from mosquitoes at all.
Nope. Blood transfusions, maybe a needle stick injury, other parenteral ways. They have a short incubation period. And importantly, no clinical relapses like with VVAX or oval.
That's an incredible level of detail. But why? Why classify them so meticulously? What's the practical point of knowing if it's autophonous versus introduced?
Oh, it's absolutely critical.
I help you.
Because being conservative in classification, like if you're unsure, leaning towards calling it introduced or autochthonous rather than imported it ensures the programs stay highly responsive. Hyper alert.
How so?
Well, imagine mistaking a tiny spark, an introduced case, for just an isolated import. Or worse, overlooking a genuinely local case because you thought it must be imported. This classification system, it's like the fire alarm and the response plan all rolled into one. It triggers the right level action, ideally the most aggressive response needed to prevent reemergence.
Okay, that makes sense. It dictates the scale of the response. And once you've classified them, you investigate the foci, the hotspots.
Exactly. And a focus investigation isn't just about the patient. It combines that case investigation with looking at the mosquito's entomological assessment, checking the environment, ecological surveys, and even assessing the interventions already in place.
And this is done quickly.
Ideally, yes.
Yeah.
By a specialized team, hopefully within 1 to 3 days of the case being notified. Especially vital for PV-vax because its gametocytes develop fast, meaning it can start spreading to mosquitoes very quickly.
And it's not always neat and tidy within one area, is it? You mentioned cross-border issues.
Oh, definitely. That's a real headache. Cross-border foci. You trace a case, but the source might be across an administrative line, maybe even a national border. Suddenly, figuring out the source becomes a coordination nightmare.
Right. It really drives home that this isn't just a local or even national fight, it's international.
Absolutely. And to help manage all this complexity, mapping is crucial. Both old-school paper maps and increasingly electronic maps with geolocation. Tracking cases, tracking those foci visually. It just makes investigations much more efficient. And it helps reveal those important geographical patterns and risk.
So the detective work on the ground is incredibly detailed. Patient history, mosquito patterns, geography. But what about the bigger unseen battles, the ones happening at a molecular level?
Ah, yes. That brings us to the crucial fight against resistance, both drug resistance and insecticide resistance. Huge issues.
Let's start with drugs. Monitoring drug efficacy. How do they know if the treatments are actually working?
The gold standard here are therapeutic efficacy studies, or TES. These are absolutely vital. They directly guide national treatment policies, telling countries which medicines they should be using, which ones are still effective.
And there's a difference between drug resistance and treatment failure.
Yes, a very important distinction. Drug resistance is the parasite's actual ability to survive or multiply, even when there's enough drug in the system. Therapeutic failure is broader. It's just the inability to clear the parasites or prevent them coming back. Drug resistance is only one possible cause of therapeutic failure. Others could be poor adherence, wrong dose, vomiting the drug.
Ah, I see. And there's a specific threshold for changing policy.
There is. And this is where it gets really concrete for public health. The WHO recommends changing the national malaria treatment policy if the overall therapeutic failure rate hits 10% or more. Or, looking at it another way, if the cure rate, the parasitic cure rate, falls below 95%.
Wow, that's quite a clear line.
It shows just how critical these ongoing studies are. They directly dictate national strategy. These 2ES are conducted at carefully chosen sentinel sites.
Medicinal sites.
Yeah, they could be a single clinic or a group of facilities across districts, even provinces. Depends on the transmission intensity in the area. And they're repeated regularly, at least every 2 years, to keep tabs on how well the drugs are working.
Okay, so that's keeping track of the drugs. What about the insecticides used against the mosquitoes?
Equally critical. That's where entomological surveillance comes in. It's the cornerstone for guiding vector control, fighting the mosquitoes themselves.
What does that track?
Key things like which Anopheles species are present, how many there are, their density, where and when they bite people, and crucially, their resistance to the insecticides we use in things like bed nets and indoor spraying.
And resistance is a big problem here, too.
A relentless one, yes. Mosquitoes evolve. They develop physiological resistance to the insecticides used in long-lasting insecticidal nets, LLINs, and indoor residual spraying, IRS. You have to constantly monitor this resistance. How common is it? How strong is it? Low, moderate, high? And what are the mechanisms behind it? Molecular changes, biochemical pathways. It's a constant arms race.
And knowing this helps decide what to do.
Directly. These aren't just academic findings. Understanding the resistance profile tells you which insecticide to use for IRS. Maybe you need special nets with synergists like PVO nets, or perhaps you need to rotate different types of insecticides to manage the resistance, slow it down.
It's not just the spray either, right? You mentioned the nets themselves.
Exactly. For the LLINs, you also need specific monitoring for their durability. How long do they actually last in people's homes? That's their survival. Are they getting torn? Physical integrity? Has the fabric holding up? And crucially, is the insecticide still effective? That's bioefficacy, all over their expected 3-year lifespan.
And that tells you when to replace them.
Precisely. This data guides the replacement strategies, making sure communities stay protected effectively.
Okay, so with all this data pouring in, cases classified, resistance monitored, what happens when things suddenly go wrong? When the unexpected strikes? That brings us to epidemics.
Anticipating and responding to malaria epidemics. A huge part of the strategy.
How is an epidemic actually defined in this context?
It's generally a sharp increase in cases, either in an area where malaria is usually rare, or maybe a seasonal spike that goes way above the normal pattern for that time of year. It can also just mean the number of cases overwhelms the local health facility's capacity.
What causes these epidemics?
It's often a complex mix. Natural factors play a big role. Things like extreme droughts can lead to malnutrition, which weakens people's immunity, or events like El Niño.
Ah, El Niño. I've heard that linked to malaria.
Yes, it can cause big changes in rainfall, temperature, humidity, basically creating perfect conditions for both the malaria parasite to develop faster into the mosquito and for the mosquito populations themselves to boom. But human factors are also key.
Like what?
Things like large-scale population movements, maybe due to conflict or economic reasons,
Right.
or big infrastructure projects like dams or irrigation schemes that might accidentally create new mosquito breeding sites.
So how do you prepare for something potentially driven by, global climate patterns or sudden displacement?
That's where the epidemic surveillance system comes in. It's actually a fantastic example of a proactive public health system. It works on 3 different layers, kind of like nested timeframes.
3 layers. Okay.
First is forecasting. This is long-term, looking maybe 6 to 12 months ahead. It's often based on those large-scale climate signals, like El Niño, which happen in irregular cycles, maybe every 2 to 7 years, predicting those big shifts that could trigger widespread epidemics.
Seeing the storm clouds way off on the horizon.
Kinda, yeah. Then there's early warning. This is more medium-term, typically looking about 3 months ahead, usually before the main transmission season starts.
What data feeds into that?
This relies on more regular monitoring, maybe monthly or even every 10 days, of local conditions, rainfall, humidity, temperature. But other things too. Mosquito numbers, larva density, the nutritional status of the population, any changes in drug or insecticide resistance, significant population movements. All these add to the warning signals.
Okay, so forecasting is long-term, early warning is medium-term. What's the third layer?
Early detection. This is immediate. We're talking days, or at most 2 weeks. This is about recognizing the start of an epidemic right as it happens.
Oh.
Usually by seeing a rapid change in the number of local cases, the incidence, comparing the current data, often in real time, to preset thresholds or expected levels for that specific place and time. It's like hitting the emergency button the moment that critical line is crossed.
And if that button is hit, if an epidemic is confirmed?
Then rapid response is crucial. getting interventions ramped up quickly. And then, importantly, after the event is over, a post-epidemic working group gets together.
What do they do?
It's usually a mix of experts, epidemiologists, entomologists, clinician, lab tech, statistician. They do a retrospective evaluation. They look back at the impact, how effective the response was, and critically, how well the warning and detection systems actually performed. Did the forecasts work? Did the early warnings trigger the right actions? It's a vital feedback loop to improve for next time.
That makes sense. Learning from every event. And this idea of evaluation, it's not just for epidemics, is it? There's ongoing monitoring and evaluation, M&E, for the whole program.
Absolutely. M&E is continuous, it's overarching, and it's not just about counting cases. It's really about accelerating progress towards elimination
How does it do that?
by making sure plans are actually on track, by helping allocate resources, effectively putting money and effort where they're needed most, also ensuring accountability, both to funders and the public, and crucially, identifying what strategies are truly working and which ones aren't, learning and adapting constantly.
And a key tool here is something called stratification.
Yes, stratification for precision. It's a way to pinpoint which population groups are most affected by malaria and what the key factors, the determinants of risk, are for them.
How does that work in practice?
It involves combining different types of data. Epidemiological data, obviously parasite prevalence, case trends, but also climatic data, temperature, rainfall patterns, seasonality, environmental factors, socioeconomic data like poverty levels, employment types, and demographic factors, age, sex.
That's a lot of data streams.
It is, and mapping these indicators visually is really powerful and helps program managers see the geographical variations clearly, see the hotspots, understand the local risk factors, and then target interventions with much greater precision.
And even the surveillance system itself gets evaluated.
Oh yes, the system itself undergoes evaluation, usually in 4 stages. Planning it, preparing for it, like defining indicators, methods,
Sure.
doing the evaluation, fieldwork analysis, and then dissemination, sharing the results so the system can be improved. The continuous cycle of refinement.
Always trying to make the tools sharper.
Exactly. And ultimately, all this effort ties back into public accountability. When information is shared publicly, maybe through management dashboards online or regular reports, it allows everyone, politicians, patients, ordinary citizens, to see how things are going, track the services that are being funded.
And that puts pressure on managers.
It encourages managers to be more responsive, builds trust, and helps maintain momentum. Transparency is really vital for sustained public health efforts.
So bringing this all together, what's the big takeaway? Our deep dive today really shows that the fight against malaria isn't simple at all. It's incredibly dynamic. It's intensely data-driven. It relies on this sophisticated surveillance, really understanding every single case type, tracking the relentless evolution of resistance in both parasites and mosquitoes, and having this proactive, multi-layered approach to predicting and handling epidemics.
It's an immense amount of work, isn't it?
Yeah.
Often unseen, meticulous work that goes into just tracking this one disease.
It really highlights how vital information collection, analysis, and then strategic response are, not just for malaria, but for saving lives and actually getting to that goal of elimination.
It really is a powerful testament to how detailed data, when used smartly, doesn't just inform public health, it transforms it. It becomes a precise, powerful force.
Absolutely. So as you go about your day, maybe think about this. How could these incredibly detailed, data-driven approaches we've talked about for malaria surveillance, how might they apply to other public health challenges you know about? If you were doing a deep dive into a different health issue, what critical data points would you prioritize collecting and analyzing, and why? Something to ponder.